Welcome everybody. My name is Ben Smith. I'm the Translational Fellow here at the Centre for Oncology Education and Research Translation, or CONCERT. I'd like to welcome you all to Liverpool. Thanks for coming out for this eHealth implementation workshop, which is being jointly hosted by the Implementation Science Community of Practice and CONCERT. I'd like to thank both of those organisations for their administrative and financial support of this event, without which it wouldn't have been possible. I think we can all agree that eHealth holds huge potential in terms of increasing the accessibility, the efficiency and the quality of healthcare. And I think some of the work being done at CONCERT, for example, the Prompt Care project led by Professor Alpagurgis and involving many others in this room, is really an example of that, of the promise of eHealth, and that project's trying to integrate patient-reported outcome measures into the clinical information systems in the hospital. But in order to really achieve that promise, we need to make sure that eHealth initiatives are effectively implemented, which has proved somewhat problematic. Hence, the reason for this workshop, to really try and offer some both theoretical and practical guidance to all of you, many of whom are involved in eHealth projects, and I hope that you'll walk away from today feeling a little bit or with some useful information to help you with those projects. So without further ado, I'd like to introduce the first of our keynotes for today, Professor Enrico Coiera. Professor Coiera is the Chair in Medical Informatics within the Faculty of Medicine and Health Sciences at Macquarie University. He is Director of the Centre for Health Informatics and the NHMRC Centre for Research Excellence in eHealth. His research often focuses on understanding the human side of technology, trying to improve how clinicians and consumers can safely and effectively make decisions and communicate, as well as focusing on the broader challenges of healthcare system redesign. Thanks very much, Enrico.
Good morning. It really is a pleasure to be back here at Liverpool. Today is really interesting for me too, because if I think about the science of informatics, which underpins eHealth, there's no topic that's more interesting or challenging than implementation. Implementation is the moment you take a protocol, an idea, a workflow, a piece of technology, and try and make it fit in your world and try and make it a working part of what's going on. And that process of fitting the construct with the reality is implementation. And I'll talk a bit later on about fitting work. That's what it's all about. If there was going to be a mental model for my talk, it's to let you know that what I'm talking about is the square peg and your organisation is the round hole. And Anne will, I think, talk a lot about how to make that peg rounder through design. Is that fair enough? Yeah, polish it and through co-design. So what I would like to do really is to give you a few tools, some models that will help you think about the process of implementation and hopefully make it a little bit more understandable. So I want to start by just describing what I consider are the two worlds of eHealth. And the first, this is the Star Trek world, isn't it? This is the exciting big data, analytics. The world is going to be transformed. It's all going to be shiny universe of informatics. And if you go to any trade show, this is what you're going to see. And yet, if you are in the business long enough, you start to see other stories, don't you? Things go wrong. Things cost a lot more. Things aren't necessarily well received, despite government saying we should like them. And even large companies struggle in the health space. So it ain't easy. The other part of the story is that the promise of eHealth has been, for example, that it will make healthcare safer. And this is a classic paper by David Bates of New England Journal now from probably a decade ago. And about a year or two later, we published a paper which said, look, health IT is fantastic, but we're noticing that we're hurting people as we go. There seem to be adverse events. There seem to be deaths through the poor use or poor design of technology. And there has been a huge pushback to say, look, don't criticise the thing that will transform healthcare. Well, it turns out that that debate has now shifted and people recognise that, just like anything we do, there are side effects and unintended consequences. And if we don't get the design and the implementation right, it's more than frustrating. It affects patient care. This paper here just came out, I think, a year or so ago. We were given access by the English NHS to all of their incident reports, which were IT related, and there are about 800 of them. And out of that analysis came a recognition not just that there is harm and risk, but that the nature of healthcare means that these can be large-scale harms. So what have we got here? That's 850 events, right? You can see it potentially hazardous. Deaths were noted, and we've noticed deaths really everywhere. And what we saw here is that large-scale events were really common in the sample, about a third of them. And I don't know if you saw yesterday's Australian. So there were about 5,000 Northern Territorians who had referrals or other information sent about them and not received for 18 months. So they didn't even know that these critical pieces of information about their care had been sent and not received. And so there was a question about how do you design a system in a safety-tolerant way, in a way we would design any clinical process to be safe. So implementation is really important because it affects other parts of care, not just the thing you're trying to look at. Okay, that's the kind of boogeyman, be careful thing. But it is now recognised. So in the US, the number one patient safety issue this year from ECRI was health IT and workflow. So the biggest issue facing US healthcare organisations is the impact of health IT and the fact that the workflow doesn't fit what the technology makes it do. All right, so this leads me to say that there are what I would call sacred and profane parts of eHealth. The sacred part is that lovely Star Trek world, and you'll have endless discussions about technology. But the profane is, why does paper persist? Why are there sticky notes on the walls? Why is it so hard to get change? Why do people complain? Those doctors, those nurses, why are they complaining when we're making things better? Why is implementation so hard? Why do things go wrong? Why do people work around the beautiful technology that I've built? Why are you not doing what you should do? And there are lots of reasons for failure. The first is simply that people build and implement independent of the evidence base. In every other aspect of healthcare, we try to be evidence-based. But it seems in eHealth that we seem to think, well, it's just a practical thing you do and there's no research to guide us. Or the research doesn't hold here because we're special, we're different, which are all the arguments that happened 15 years ago in EBM. The evidence base is growing and does exist. There are some situations in which there is still yet no evidence, and that's not what you can do about it. But the main difficulty, I think, is that people have real challenges in taking what the evidence says and fitting it to the context, and that's really what I'm going to focus on today. So let's start with what the evidence tells us, and I'll give you a little model to sort of understand that. And this is probably all of the meta-analyses of eHealth on one slide, so it saves you a lot of reading. So what do we know the evidence says at the highest quality level? That electronic records, in terms of efficiency, make nurses faster, make doctors slower. Read from that what you will. Records are improved in terms of completeness. Every time we try and demonstrate an impact on length of stay or outcomes, there are no impacts. Records do not change clinical outcomes. They're a piece of infrastructure. And if you think putting a record system in is going to improve care, then you haven't read the literature. The next thing, care pathways, plans, really important impacts on process outcomes. So practice variation does decrease. Improve compliance with standards of care. We can see improvements in critical clinical processes. So better quality test ordering, ordering the right drugs. Again, and this is really hard to accept, minimal impact on length of stay, death, and other outcomes. So this class of technology is all about improving efficiency and reducing variation, and it does it very well. Telehealth, another very important area, makes patients happier because they don't have to make the trips that otherwise they would have to make. We do see outcome changes here in some classes of care, so chronic illness, cardiac care, etc., but not always, and not always economically viable. So if you look up at in the English literature on the demonstrator, the large-scale demonstrator, where they're looking at lots of chronic illness, they were able to show improvements in clinical outcomes, but they couldn't, even making heroic assumptions about reductions in technology cost, show economic benefit. So, still challenging. Then we come to something at the bottom which people really think about, which is decision support, which is providing guidance on decision making. This is the only class that repeatedly shows strong and powerful impacts on patient outcomes. And it is a surprise to me after 15 years that we still focus on the record as the thing we do, when the thing we should be doing is improving decision making. The record is just the road, and the decision support system is the transport system, is the cars, it's everything else. And if you just build roads, nobody's going to get anywhere unless you do the rest of it. So the other thing is, now you step back and say, well, that's all a bit disappointing, Enrico. What am I doing here? What I'm going to say is, look, this is exactly what you should expect for these different pieces of technology. Then these are not bad results. These are exactly the results you would expect if you thought about what they were doing. So here's the first model. And this is simply a model of steps in decision making. You know, if you're a clinician or a consumer, you know, you interact with the technology, you might receive some information. That information may or may not change your decision. That decision may or may not measurably change the process of care. And that process of care change may or may not impact outcomes. Each of those steps, there's a probability along it, isn't there? There's no guarantee that receiving information will change decisions or outcomes. And in fact, it drops down. It's sort of a waterfall all the way down. So what does that mean? So each stage has different value. Let's talk about that. But as we go along, just the likelihoods of things happening decrease. So let's now look at each of the steps of that chain, and I'm going to put some maps of each of those technology classes on that. So let's look at what I would call value signatures. So that's the electronic record. Down here, probably it costs us to use it because it demands more of us than we would on paper, right? It provides more information, but really, it's never really going to have a strong impact on outcomes. It's really about bringing information to people, but it's not necessarily about making that information actionable. Care pathways, very strong impacts on those middle stages, right? But again, minimal impact on outcomes. And I've got to say, these are just made-up curves, just for educational purposes. Teleconsultation, really strong benefits early on because what we're doing is replacing face-to-face with teleconsultation. So it's a substitution, isn't it? It's not an improvement. It's not trying to say the interaction between clinicians is going to be improved. What we're going to do is replace it with a cheaper alternative. So we shouldn't be disappointed. We should be really happy that the quality of care is the same, but we shouldn't demand that it be more because that's not the point of that technology. And then decision support. Interestingly, asks an awful lot of us at the very beginning. So we'll be one of the complaints is decision support requires too much engagement. You know, I've got to put too much information in to get the output I want. But there are huge benefits on the other end. So what I would argue is that those are the signatures which are inherent in those different pieces of technology. And then when you go to bring a system to the world, you should already have clear expectations about where in that chain of events you're going to optimize. And if somebody says we put a record system into a hospital and we didn't improve outcomes, well, so what? That wasn't the point of the intervention. Have you misunderstood the intervention? So here are the implications. Information only has value when it changes a decision. And you'll hear in the discussions of big data and analytics, people are starting to talk about making that information actionable, which is the right thing, because it doesn't matter what associations you show in the data sets, it doesn't matter what models you create that are predictive. If you can't put it in the hands of a clinician in a way that is meaningful and useful and fits in their workflow, nothing will happen. So if you build a big data institute, which is all about data analysis and model building, and you don't have a twice as big institute on translation, you've misunderstood again what you're trying to do. The electronic record is too upstream to make decision changes. So therefore, what that means, I think, is you have to see what you do as putting together a bundle of those components to get the outcome you want. If your focus is on outcome changes, you've got to have a record, but you've got to bundle it with decision support or something else to make a difference. And so good examples would be medication ordering, where you've got a record underneath, and then you have decision support in terms of helping people pick which are the right medications, picking the right version of the medication, and making sure there are no interactions, etc. So, and those classes of intervention do make differences because it's a bundle. And just in case you want to know more, both this and the next thing I'm going to talk about come from my textbook, which came out, new edition last year, so you can read about it there if you wish. Okay, that's part one, which sort of set our expectations around what an implemented technology might in principle do. But I also started at the beginning by saying, look, there's something about this fitting of the technology or the guideline to reality, which is about fitting with context. And context is where it gets interesting, because we see huge variation in outcomes doing the same thing in different places. In fact, that's the norm. If you implement a system at Liverpool Hospital and then go and do it at Westmead, even if it's the same system, you will get a different outcome. You will get a different outcome. So here's just one nice study with an order entry system. So, you know, ordering medications, ordering tests. And they looked at the same system implemented in 62 different US hospitals and tried to understand how much the technology was responsible for variation. And you can see here it says about 27% of the difference could be due to the technology, and all the rest was local context impacts. So in other words, your outcomes are highly dependent on the place in which you do things. And you can see here they're thinking, you know, maybe 65% of variation is local. So this implementation thing is not just something you have to do. It has a profound impact on the outcomes of what you do. So why is that the case? What is about local context that gives us such variation? And one clue is simply that different places have different needs. So what this study here simply showed was, look, we put a medication ordering system in and into both medical and surgical, and guess what? Uptake was different, satisfaction was different. Well, yes, because the use of medications is very different in those two settings. In one, it's probably very routine pre and post-op. Here are the sets we've got, whereas maybe in a medicine-focused ward, we're really going to have a lot more variation and requirements to use the higher function parts of the CPOE system. So the responses of the organisations to the same thing are different because their work is very different, for example. But the piece I want to talk to you really about that I think is really interesting is to say, look, what we're doing is knowable and researchable. And so this term implementation science really says that what happens when you bring something to the world is not a random thing. It's a knowable thing, and we can bring theory to do it, to understand it. And the one theory that I really enjoy, and I think is very, very interesting because it explains a lot at a high level, is complex adaptive systems theory. We hear those words a lot in terms of healthcare. It's complex, blah, blah. What does that really mean? And what does that mean for implementation? So I'm going to try and give you some models which are hopefully concrete enough. So the first thing is to say, let's just look at a hospital, and here are some things we want to do, some functions that we would like to occur. And we have a set of processes which do that. So we want to discharge patients. There's got to be a whole process for creating that discharge. We also bring in, and those things already start to connect up, and they don't connect one to one. They're a bit complex. Then you bring in tools to do that, and those tools also connect up to function. And all of a sudden, you start to create a network of things. You can start to see that there are multiple connections, and some things connect more with others. It starts to get messy, and you can see I've just drawn a couple of lines. If you were to get a diagram of all the information systems in this hospital and all the connections and interfaces, it will be a beautiful plate of spaghetti. And then, of course, what you do is you come in and say, look, I'm going to change one of those pieces. I'm either going to replace it or add to it. And you're not just changing the box now, you're changing where you fit in that network, and all the things that are connected to it will be affected. So the model that works really nicely is to is to think about this as a complex adaptive system. And I'll use in a minute an analogy from genetics around fitness and fitness surfaces. But let's first just be really clear about what we mean by that CAS term. So complexity simply is how many connections there are between elements. And the more connections and dependencies there are, the more complex the system is. You've probably heard the analogy, the difference in complexity, say, and complicated. So a complicated system has controls things in modules. So an aeroplane is a very complicated construct because there are lots of modules, and the complexity is minimized because we have few interfaces between the modules. And one of the reasons we bundle in healthcare, we bundle things together, is because you minimize complexity by creating a bundle. The next thing is there has to be some kind of a measure of how well you're doing, some kind of a fitness function. Just like in genetics, an organism is more or less fit for its environment. And then finally, you have to have a source of variation. So in genetics, we know how variation is generated. Variation happens here in local context fitting, changing things. So fitness simply means that if you imagine now a surface, and the higher up you are, the fitter you are, that as you change a system, your goal is to move up that fitness space, to do well, and that each organisation has its own curve. What it shows here is that the same thing happening in different places will have a different outcome because the space of fitness is different for them. So, and this is what the geneticists who study evolution have. They would create what they would call a surface, which is it's a rugged surface, and you can see across the bottom they've just got two phenotype attributes, which could be in any part of the system, that you want, and then fitness, how well are we doing? And you can imagine how complex it is because there are actually more than two attributes in any organisation out there. So your journey is to try and find the peaks as you go. Now, what does complexity tell us about that surface? Let's start at the top. If you've just got that simple network I drew for you at the beginning and nothing connects to anything, it's a very simple landscape. There's just one beautiful peak in the middle which you can all try and go to. It's very easy. As you increase the number of connections in there, you start to get a rugged landscape, but it's still okay. You can still find where the peaks are. There are flat areas and there are mountainous areas. When it's fully connected, you essentially have random fitness, which means that it doesn't matter where you go, you're not going to do any better than anywhere else, really. So those peaks are very small. So one of the challenges in healthcare is we have very complex organisations, highly interconnected. We're much more like the bottom than the top, which means that anything you do has a very low likelihood of improving overall organisation performance. It's kind of a challenging thought, isn't it? And in fact, there's a paper I've got probably from 4 or 5 years ago in BMJ called about clinical inertia, which is why is it so hard to change? Why have we, after 15 years in patient safety, not really shifted rates of iatrogenic harm? what's going on? We've spent millions around the world. Still, all the greats of patient safety will say it's an unfinished challenge, partly because of this issue, which is that you can fix one bit, but all those connections and dependencies elsewhere make it very hard. So complex adaptive systems theory tells us the job that you've got as you build things is challenging, and managing complexity, therefore, is one of your goals. If you come in and add on top of what's already there, you're adding complexity. So you're going to have to decommission, you're going to have to modularize, you're going to have to remove things that are old or redundant. If you don't create space for your intervention, you ain't going to get where you want to go. The other thing, and I just sort of mentioned this, is as you get more complex, fitness decreases. In other words, the outcome you want becomes harder and harder to achieve. So not only is it harder to find a better place, but everywhere is of lower value. Again, that's all. It's all in the text, or you can find lots of papers on this. So implications. Finishing up. Improving performance in the face of complexity is hard. So whatever you do, it doesn't matter what you're implementing. One of your challenges is to create space in complexity. You must get rid of stuff to create space for what you're doing. One useful strategy is to think of modules or bundles, because if you can put everything within a box and have few interfaces to the rest of the organisation, complexity is managed. Think of decommissioning, think of getting rid of old stuff. Don't introduce a new form unless you get rid of an old form. Don't add another field to the screen unless you get rid of a field. Don't add a click if you haven't taken a click away. The last thing, it's interesting, people know about the notion of error catastrophes in genetics. This is when an organism evolves independently of fitness function. In other words, it's not changing because it's being driven by the environment. And what happens is it just goes randomly, and eventually you just find a very deep valley and the species just dies. And so if you think about healthcare, we get reorganised, every couple of years, independent of output, don't we? And that reorganisation is not driven by fitness functions. Moving on. So to finish up, why is e-health hard? And again, I know it sounds it's hard, don't do it. I'm saying what you're doing is hard and important. We need, therefore, to be wise as we progress forward. It's a complex intervention in a complex system. Hopefully now you've got an intuitive idea what I mean by that. I would argue that e-health is amongst the most complex of the interventions we try in healthcare because it fits all the way across all of the systems that we play with. That fitting, I haven't used this term before in the talk, but it's implicit, is not technical, it's socio-technical, right? So it's all about people and processes and technology, and they all come together. If you see it as a technical problem, you will not get there because you've missed part of the space. You're going to hear in a minute about co-design and other things, I'm sure. Implementation isn't a point in time. Implementation never stops. You adapt as you go all the way along, and workarounds are part of the implementation adaptation process. So I don't see workarounds as bad things. I see them as a continuation of implementation, taken out of the hands of the designers and now taken over by the people who work with the system. And I think I'll finish with the first law of informatics, which you're also going to hear about at the beginning of the next talk, which is that we've got to focus on why we're here and what we're trying to achieve, and never think in technical terms at the beginning of the project. Thank you.
Thanks very much. Yeah, we might have a couple of minutes for questions. Whilst we're doing that, I'm going to try and turn up the volume because I understand that things are a bit quiet at the moment. And do we have any questions from in the room? And Jordan might be able to read out any questions that come from online. But Norbert, do you want to start as well?
Thank you for this wonderful talk. If I can go back to some of the first slides, some basic assumptions. What would be the case if we don't go the e-health route. So, what would be the alternative? What are we missing out or not missing out? And is there a way to put some, let's say, opportunity costs on this? Particularly when you break down what has worked well, like decision guided outcomes. Would that be a way where you can put some dollar figures or opportunity cost figures on it? If we would do this, what would we miss out to actually help the cause, which works, and to basically discard which doesn't work?
It's a very good question. So nobody is saying.
Sorry, can you just repeat?
Oh yeah. So the question was, what are the alternatives to eHealth? Should we not do it? What are the opportunity costs? Are there things that we should be doing differently? And so I don't think we have an alternative because we've now built a system that is dependent. We're IT addicts now, and in fact, most of modern systems, aerospace, traffic, everything we do is now IT dependent. We would struggle to do the things we want to do without technology. The question really is, how well are we doing? And I would argue that there have been huge missed opportunities because we've done the wrong thing. The question then is, did we know what the right thing was at the time we made those decisions or not? Or are we learning? And look, the truth is, you can always find people who will say, you should have done X. I mean, several times I've said, don't do that. Don't build a national summary care record in the middle. There are better things to do with your dollars. But there has to be somebody on the other side who recognises the evidence, and when there are lots of competing voices saying do the other, it's very hard. So I think the reality is that overall we're doing the things that in aggregate people believe are the right thing to do. But I would say the evidence now is very clear about some of the things we shouldn't do. And so, for example, I've been debating for years that we don't wait for decision support. Let's build a record first and then have decision support. That's a misunderstanding. What you do is you start with both a bit of record and a bit of decision support and ramp both up. That way you're getting benefits, because otherwise there's no benefit to people to use the system. Why should I use an electronic record that takes twice as long, gets in the way of me seeing my patients, and I see no benefits in using it? So there are all sorts of challenges in taking that other route. So I think the costs have been high globally, not nationally, but it just takes time for wisdom to percolate. That's the same with anything in healthcare. We know there's 10 to 15 years delay in evidence being implemented in the practice. So I would argue this is the same phenomenon.
And you've glanced on this, Enrico. I mean, one of the fundamental problems we have, I think, is that the electronic medical record we have is so fundamentally flawed in terms of their ability to actually do what you're suggesting, which is clinical decision support, maybe clinical informatics and those types of issues. When you have to write a letter to somebody in an office somewhere to get a simple report back on some clinical decision. Would you have any comments on that? I mean, what do we do with the fact that Epic and Cerner and Allscripts and those other ones really are only just starting to grapple with this? They do create problems for us.
So I think there are two parts to it. One is most of those large commercial systems do have decision support functions, not always sophisticated, they do. Customers don't buy them because they don't think they're valuable. So there's nothing to stop you saying, in our implementation, we're going to make sure that we get some of those benefits. Secondly, if you demand those functions off the vendor when you order the technology, then you're going to get them. So I think if the customer doesn't value that, then nothing else will happen. So they're simply responding, I think, those vendors to what customers are happy to buy. And for whatever reason, we are stuck in a mindset, not just in this country, but everywhere, that it's about the record. When I keep on saying it's not about the record is just infrastructure. So I think it's up to us to expect it and to demand it.
Okay, is it a quick question, Kathy?
Very quick question. You did touch on it. You touched on the fact that one of the problems with the record is that doctors are expected to spend more time entering data than they ever were before. And one of the things that won't work in terms of decision decision support is if you don't have the accurate data in the record to base the decision support on. So there's a kind of fundamental paradox, which is that the people who are perhaps the most pressured in the system and the least likely to want to be data entry clerks are the people who are expected to enter the data off which the decision support works. So how do we address that in the system?
So the question is, are we stuck because we're asking more of doctors in terms of time to create records, and then if they don't do that and data quality is poor, we won't have good decision support? So there are two parts. Number one is you don't need the record for decision support. There's nothing to stop you in a doctor or nurse initiated way to request help. Siri, what's the way? So that's the first part. So there is a misunderstanding that you must have the record. That's not true. But the second part is, whoever said that this is doctors' work? It's only that it's being given to us in that way. So what's happening now, for example, in the US is strong emphasis on scribes. So people helping clinicians. And in fact, there's nothing worse than seeing a registrar and an intern pecking at a keyboard for 20 minutes when they should be doing real work. So you could argue in terms of economics that you save money by hiring scribes to do that work. And the scribes can be absolute experts at navigating those beautifully designed interfaces from the corporate customers. So there are solutions around it. And I think often people just accept what they're given rather than saying this is not what we want.
Can you join me in thanking Enrico again for